Good morning, everyone. Thank you for having us. We would like to invite the Session 1 speakers, Dr. Tien Lee and Associate Professor Prashant Tibrewal, to come to the stage and join the panel, please. I'd like to begin by introducing Dr. Tien Lee, who will be presenting on the definition, epidemiology and pathophysiology of metabolic syndrome. Dr. Tien Lee is an endocrinologist with private practices in Adelaide City and Clarence Park, and also consults regionally in Murray Bridge, Naracoorte, Yankalilla and Kangaroo Island. Formerly a senior electrical and computer engineer in a Fortune 500 company, he now focuses on assisting patients with metabolic multimorbidities and endocrine feedback system issues. Dr. Lee completed his PhD on stress hyperglycaemia with scholarships from NHMRC and RACP Kincaid-Smith. He's authored well-cited papers in respected journals, including Critical Care Medicine, Cardiovascular Diabetology, and International Journal of Stroke. I now welcome Dr. Tien Lee to speak.
Good morning, everybody. Let me just check the system first. Okay, good. So I'm Dr. Tien Lee. Good morning to everyone, and thank you to IMAR and I believe quite a few people, including who has been involved. And I think we have a pretty good program here, and I think it's actually quite well organized based on my talk. And I'm going to talk about metabolic syndrome. I've chosen this picture. Please just remember that anything I put on my slides are for educational purposes only. I don't have express permission for reproduction. Okay. Now, this picture was actually gotten from the internet, and I think it's good because obesity, which we're talking about later as well, specifically, and metabolic syndrome is like the elephant in the room. But the problem is we don't always address it. Okay? And how often have you all actually come around as fellow health professionals and say, hey, hang on, that's metabolic syndrome, let's write it down there as a differential diagnosis. Okay? We would say, oh, he has diabetes, but we might not say he has metabolic syndrome. So I think it's something that we hopefully would talk about today. So I'm an endocrinologist, so I actually deal with general endocrine, but I specialize in diabetes. And one of the things that I do that might be a bit different is I specifically look at remission and reversal of diabetes as an endocrinologist. And I will talk about it in my second session as well. The other thing is I do weight management as a result of that. Okay, I'm not going to be talking about weight management later on today, but just as a background. Now, I don't actually receive any honorarium for this talk, but I have been bribed by everybody else, both for-profit and non-profit, including Australian Diabetes Society and Diabetes SA. So you can take it for granted that I will not be biased against anybody because I'm bribed by everybody. Okay, so and when we talk about metabolic syndrome, I need to make sure that you are aware that there is a lot of eponymous names for it. So it can be called the insulin resistance syndrome. It can be called MET-S, MET-C, can be called the fat neck syndrome as well, because they used to actually try to diagnose it with the circumference of the neck. And then there you have the deadly quartet. So 4 different things, mostly upper body obesity, hypertriglyceridemia, and hypertension, and insulin resistance. So that was the deadly quartet. Syndrome X, which came later, we'll talk about it and the history and the definition. And hypertriglyceridemic waist and the toxic waist syndrome as a result. And I chose this picture, and this actually goes to Prashant's talk later, potentially, because we need to know that there is a lot of stigmatization around the topics we're talking about today. And people talk about toxic waste, as if everybody with metabolic syndrome actually gets it because of the junk food that they take. But that's not true. Some people don't eat junk food and they still have these problems. Okay? And the problem too is it actually goes in a cycle. Those people get depressed, they go into antidepressants. Guess what happens? They then put on weight because of antidepressants. And then they might have psychotic issues, they are on antipsychotics. And while I don't present the data today, you have to take it for granted. The people with depression and those psychological, psychiatric issues, the prevalence of metabolic syndrome in them is more than double that of somebody without those conditions. We're talking about 50-60% prevalence, okay? And those are from Australian data. So everything I present here will generally be from Australian data. Now, next one. Just to go through the definition, I will go through and talk about the history. And part of it is for us to understand that this is not a single specific illness diagnosis. It's a syndromic diagnosis, a bit like PCOS, polycystic ovarian syndrome. It's a syndromic diagnosis. And I believe all of you know that PCOS, you can have normal ovaries and still have polycystic ovarian syndrome. Okay, so it means that we are not stating what is the underlying factor that is causing it. So we're not naming it. So how did it come about then? Well, first of all, we have these grades of endocrinology from the past. Jocelyn. There's still a Jocelyn Medical Center in US, which is one of the center of excellence for diabetes care. And he actually associated diabetes, hypertension, and hyperuricemia. So next time you see a person with gout, don't forget, it might be part of this problem too. Okay. Now, and many years later, there were a few people contemporary to him that also noted the same thing. Okay, and confirmed his suspicion. Then 1947, someone else by the name of Vague, okay, noted that central obesity, and this was important because now, for the first time, we start to associate the body habitus, to have this predisposition. So potentially there's a link, something underlying, that is causing the diabetes, atherosclerosis, gout specifically, and calculi, renal calculi. So could be from uric stones as well, potentially. And then it continued to the 1950s when we first see the word metabolic syndrome used in literature, but nobody is given the credit because it wasn't a specific word. There's no justification, no definition. It was just written in the papers. So, but that's how we start to think of using it. So, and many years later, we have a few people coming and presenting a case series, 6 people with diabetes, obesity, hypercholesterolemia, marked triglyceridemia, which then improved with caloric restriction and a low-carb diet. Probably you all know that there is a push towards low-carb, and I'm a very strong low-carb proponent myself. Not necessarily keto, but low-carb in general. Keto is low-carb as well. So, we have a history. Okay, this history goes all the way back at least to 1967 from my talk today. And it certainly improved their diabetes status in those patients. Now, and so slowly we are starting to gather that there is all these things that clusters together and that we might be able to treat that underlying problem and actually help everything else. The blood results in the lipid, the obesity, of course, and the hypertriglyceridemia. Just a quick note that when I use the word obesity, I use it only here as a medical terminology. Just don't use it with your patients sometimes unless you know them well. Okay, can be a stigma problem. So now, and then we continue to 1977. Haler, he is actually the one that is credited to be the first person to give a definition and to use the word metabolic syndrome. So it's not that old, 1977. I was born right after that, so it's a bit old. Okay, not that old. And he used it for obesity, diabetes, hyperlipoproteinemia, so something to do with the cholesterol as well, hyperuricemia, which is not in the definition at the moment, hepatic steatosis, so fatty liver, which is also not in the definition. But I can tell you that people with a BMI over 30, they have a 90% chance that they have fatty liver. So I tell that to all my weight management patients. And most of them will say, oh yeah, actually I've been told I have fatty liver. So same thing here, but it's not in the definition. too many people maybe. And then and in the same year, somebody else by the name of Singer, he is unfortunately not given the credit. He's also used the same term in the same year, but too bad Haller is the one that we say is the one who started the definition. And then up to 1988, somebody else now in one of his lecture series actually mentioned insulin resistance as a potential underlying. But he was actually wrong. He thought that the insulin resistance was driven by testosterone. I don't know how that can be the case when there's a lot of females with diabetes, but he thought that insulin resistance was the main thing, so that was his contribution. And he called it syndrome X, so that became a synonymous word for the syndrome. When we talk about metabolic syndrome, as you can see, we are going to talk about the definition and how we diagnose it. And it's only what we use is actually only a very small part of the big picture of what metabolic syndrome encompasses. So you can see that we didn't mention anything about kidney function except for kidney stones. But obviously it's related to metabolic syndrome. And same thing with things like liver cancers. Again, we don't mention it, and it's not in the definitions generally, but they are all related, okay? So this metabolic syndrome is something that is worth knowing and noticing for the patients, because we can potentially help them before complications happen. So what are the definitions? The first clinical diagnostic criteria, so I guess you call it the definition, was from WHO. Now the words are small, so I don't expect you all to read them. And there's quite a few of them. And in fact, this is not a comprehensive, because the next slide will be the current criteria that we use. And the one that we would use in Australia in 2009 is called the Consensus Guidelines. But this few gives you some idea that we were actually on the correct path from the beginning. Generally, we talk about having at least 3 criteria, and out of generally 5 different conditions. Now, I'm going to quickly mention, with WHO, that was the first definition. Don't worry about that. Then we had the European group coming out and says, hey, hang on, we know better. And you know what? If you see any papers that talk about the European definition, remember, for some reason, they exclude all patients with with diabetes. Metabolic syndrome without diabetes. Strange. Impaired glucose tolerance and pre-diabetes is in there, but once you have diabetes, you don't have metabolic syndrome. Interesting. So if we see those papers, you need to remember that they are looking at a different group of people. The one thing that they did introduce that is interesting is the use of waist circumference. If you, that's no laser pointer. If you look at the obesity section, there is a different one. Okay. So if you actually look at the obesity section, they actually use waist-hip ratio. Now, how many of you actually use waist-hip ratio in practice? No one. Okay, it's too difficult, not practical. Okay? They took his tape. They say he's wasting time in the clinic. Should be seeing more patients. No, just kidding. But the thing is, it was not very practical. So they actually changed it to waist circumference. But you know what? I think they did the right thing. There's actually comparison studies on waist-hip ratio with waist circumference. And you know what? Waist circumference is probably the best single surrogate marker for something else, which I will talk about more in my next talk, which is visceral adiposity. In fact, I will talk about it this talk as well. Okay? And so waist-hip ratio, much harder, 2 different measurements, is actually inferior in terms of a prediction. Okay, so that was actually changed. So that's the contribution from the European group. This this one onwards, which is American onwards, is very similar to what we are doing now. Okay, which is any 3 of 5 criteria where they look at the blood glucose. So that is about 6 millimoles. But that has been changed after that to 5.5. So if you get any results from assay pathology, you notice that the normal range and reference is up to 5.5. If it is over 5.5, they say abnormal, yeah, on the fasting glucose. So that's the reason, because that is part of the metabolic syndrome definition which is 5 millimoles. It's actually 5.55 if you convert it. Okay, and then the triglycerides is always been over 1.7 and above, 1.69 here, but too difficult, we remember 1.7. And the HDL-C was different in the past, but now we have standardized to men having less than 1 or women having less than 1.3 is considered reaching the diagnostic criteria. And blood pressure is now standardized as well to 130 on 85, used to be a bit higher. And all of us are now using waist circumference. The only difference in all of those fields since 2001 is really the waist circumference on top of everything else. Okay, and they specified one for men and women. The International Diabetes Federation says, nope, we'll just use one, it's less confusing. But then they switched back. And in fact, in the next slide, and this is actually from a RACGP article that I got this one, but this is actually a 2009 consensus guidelines. Okay, they actually kept almost everything the same as the American guidelines. Okay, the only difference is instead of having a single marker for men and for women for the waist circumference, they have, you still need your tape measure, by the way, for waist circumference. Get it back. But, oh yeah, the pharma companies can sponsor, that's right. Okay, yeah, okay. So anyway, now they think that the waist circumference needs to be population specific, and there's a different table for them. Okay. Now, back in 2023, there was actually a survey in America, and they found that that the most popular definition or criteria that they use is still the American one. And not surprising, because most of the people that they see there in the hospital are going to be, I guess they consider it the North American cohort. And so there is no difference between the old American and the consensus guidelines except for that table. Okay, so it's still what we all use, and this is what we would use in Australia. Okay, so that's the definition. Now, so quick summary again so that we can remember. Metabolic syndrome diagnostic criteria: fasting sugar over 5.5 or 5.6 if you want. Okay, high blood pressure over 130 on 85. High triglyceride really over 1.7. Large waist size, waist circumference based on ethnicity or cultural background, so to speak. Look at the table, I can't remember it. Generally for women, over 90 if they are not Caucasian. Actually, I go back to the previous slide. So over 80 for the women, except if you are Caucasian, you are allowed a bit higher. And if you are men, it's over 90 or 94, depending on the place. Unless you're Caucasian, again, you're allowed 104. The reason for that difference is because even skinny South Asians especially, our risk of having a heart attack or stroke and all those other things we worry about in metabolic syndrome, the risk is much higher than even for a person who is obese as a Caucasian. Why? Don't know, but I think it's visceral adiposity. There are some papers that postulate that. It's because of the food that we eat in all those countries. We actually have staple food like rice, where I come from, noodles, and then roti, and all those other stuff, full of carbs. And our visceral adiposity is higher at a much lower BMI.
How about potatoes, which Caucasians they don't have carb?
They do have carb, but fortunately, at least in the past, and they are growing. Metabolic syndrome is growing over here too. In the past, maybe they eat more steak, I don't know, compared to their potatoes. So I don't know, okay? So it's still ongoing. It's probably not a single food item, it's the combination as well, but we don't have evidence to tease them out just yet, okay? So that's the definition, and I put this slide here. Because what is the point of knowing all this definition? What is the point of knowing that a person has metabolic syndrome unless we do something about it? So one of the problems is when we know a patient is pre-diabetic, what do? We might say, wait until you have diabetes, I treat you for diabetes. Or wait until you have no diabetes and then I can also treat you. That's the wrong way that we are doing it, isn't it? Because if we know that a patient has metabolic syndrome, really we should treat them before they have the diabetes, before they come to me. Because, because once they have diabetes, the current treatment modality, which I'm not talking about, is to treat the individual component. Now, I will talk in my second talk that maybe the right way is not to treat only the individual component, but to treat the potential underlying problem. Okay? So, what's the prevalence? How big is this issue? Now, I don't have new data, unfortunately, and I couldn't actually get a good set of data to show you all where it is actually rising in prevalence. But I can assure you that we do have data for the individual components that we have said. For example, obesity, we know it's growing in Australia. We also have more and more diagnosis of type 2 diabetes. So we know that the individual components are rising. So I'm going to tell you that metabolic syndrome is also rising, okay? But I don't have specific data. Now, this data is quite old, 2005 from the Lancet. Look at how we are doing in Australia, not too bad, in the middle of the pack. Slightly more females than male having metabolic syndrome. Obviously, one of the questions is which diagnostic criteria, so we have to look at that, okay? The numbers do vary. I got this from somebody else, and there is 2006, so not that far off. And yet, they actually report 48.2% in men and 29.9% in women. Something wrong here. Very different numbers. The other was slightly under 20%. And I think the main thing is to actually look at the data and tease it out. So this one is actually published in 2007, so not that far apart either. And really, it depends on what kind of people they actually surveyed. If you actually have people in the 60, 70 age group, you have that 50-something percent, 40-something percent, like the second one that they published. If you actually got them at the early ages, you don't have that much in terms of metabolic syndrome. So that's pretty much it. The other thing too is to note that there is a drop after about 75. Now, you might say that's a good thing. I'm going to say it's actually probably a bad thing. My reading of that graph is that people with metabolic syndrome don't last that long. So at 75, they are already dropping off. Okay? So less prevalence. Okay? So we need to catch them early as well. All right, another key point. And again, those are the different diagnostic criteria I mentioned. And as I said, the European got rid of all people with diabetes. So no wonder they are always at the lowest of the prevalence, because all the people with diabetes certainly don't have metabolic syndrome. Okay, and looking at the WHO, the later ones, which is very similar to the consensus guidelines that we are using, they are actually diagnosing more with metabolic syndrome. Okay, so that's the prevalence and epidemiology there. So what about what actually causes it? I'm going to tell you that is the answer. Not fully sure. But there are certain things that we know, because all of the studies tends to be associative study, not causal studies. So we don't actually know whether it is the cause or the effect. For example, insulin resistance, which we have mentioned, is one of the big part of metabolic syndrome. There are people who believe that it is actually a causal. So insulin resistance starts first, and then it causes the rest of the syndrome. There are actually people who think that's the consequence. It's because the patients have all these other problems, maybe visceral adiposity, hint, hint, that's my thoughts. and that actually leads to the insulin resistance, and it's so part of the metabolic syndrome. So we don't actually know which comes first either, but there are some things that we can say. So I'm just going to keep it simple here. Consumption of high energy food, here they put high glycemic food, and physical inactivity. It's actually a ratio of the two. And the postulate for the pathophysiology there, or the mechanism there, is that when we have an excess energy intake over expenditure, we are actually overloading the products of the mitochondrial activity. Okay, and the high energy food activates all the mitochondria, and then what happens then is we have all these reactive oxygen species, and we have all these toxins, which then potentially contributes to metabolic syndrome. Stress, we believe that it actually acts because it modulates and it affects the hypothalamic pituitary adrenal axis. And therefore, we know that there is a stress hormone. That's why it's called a stress hormone, right? Cortisol, yeah? And we know that people with Cushing's disease access cortisol. What happens? They grow bigger, and then they also have insulin resistance as well. So that again is the other postulate of how it's contributing. And then there is all this nutritional study. I won't go too much into them. There is this omega-6 actually, one of the amino acids, and they think that it's also potentially contributing to metabolic syndrome. I'm not going much into those because, again, all of this, we don't have very, very good papers or very, very good research, and there's no way to do a randomized control trial. So a lot of it is still postulates, okay? And there's also one other postulate which is going to tie in with the next talk as well, is whether the reward pathway is actually a thing that leads into all of this potentially. Think about it. There is studies on the endocannabinoid signaling. And in fact, they have targeted certain endocannabinoid receptors to be targeted for weight management. Haven't seen any products from any pharmaceutical companies yet. But certainly, you know, and I'm not asking anybody to smoke pot here, okay? but certainly, it modulates the reward pathway. And we do have a drug here actually today from Ipsen, Contrave. That actually works on the reward pathway. It's an anti-smoking, anti-alcohol medication. Combined, we call it, or I call it, anti-food addiction, right? Okay, so the reward pathway is something that we need to think about as well, and maybe actually the thing that starts the whole cycle. Don't know. So, but, just a cartoon here. So pretty much, remember that what we eat, the excess is stored. And other than protein, carbs are stored as fat. And in fact, it may be the worst part of it because the high carb content that we take seems to be stored as visceral adiposity. Okay, so in a study where they look at low carb versus low fat diet, they can achieve the same amount of weight loss. But the difference is the visceral adiposity loss with a low fat diet was very minimal, while that with a low carb diet was a lot greater. Okay, so carb is also stored as fat. And here pretty much says, oh, no, you fool, we might need the energy someday. But, you know, we don't always exercise and do as much as we need to after we eat. Now, and what is the mechanism or the pathophysiology after we have metabolic syndrome with the end organ effects? Again, not sure. But I chose this one because I like the theory that visceral adiposity is central. Okay, so this is one of the ones that has been published. And you can see that all the other effects comes from visceral adiposity. Now, apologies to all the cardiologists, but now they have taken over lipidology. But lipidology used to be an endocrine specialty. And we used to think about all of this mechanism. Now with cardiologists, it tends to be mostly a epidemiological stuff. What is the target? What's your LDL you need to be? But then actually we forget that the adipocytes are an endocrine organ. They produce over 100 different hormones. They actually have things that modulates, like your aromatase, modulates the testosterone and estrogen. Yeah? Fat man has big boobs. Why? Because of the estrogen effects from the adipocytes. We forget the subcutaneous fat you can liposuction off. And all the studies with all that has shown that they are not metabolically active, not much at least. Okay, so visceral adipose seems to be the big thing. And they produce not just the hormones, they also produce inflammatory stuff, so chemokines, cytokines, adipokines. And those actually regulate, hormones, yeah? So angiotensin 2. And you get all this other stuff coming in, and you get chronic inflammation. So people actually improve after you address their visceral adiposity. And then after that, you get, heart attack and stroke is actually a chronic inflammatory thing. I had a cardiologist who said that actually we are just an extension of endocrinologists. but anyway, I'm just kidding. So anyway, we just need to know that all of these are actually intertwined. Okay? And maybe there is something underlying it, because when I talk about the definition of 5 minutes, okay, cool. So we have to remember that the okay. So yeah. Okay. We'll just continue. So just remember that it's a active cell, produces all kinds of stuff. Some that I don't even mention, but it's potentially causing the problems we see with metabolic syndrome. In fact, with this this paper and a different diagram, because I said the other one I like it because that's what I believe. This one is on cancer. Okay, you can see all the things that contributes towards cancer. And what is great is if you actually remove this obsession with BMI and waist circumference, just get rid of it, you see that the rest of the diagram is still centered on adipocytes. It actually leads to the insulin resistance we talk about, part of the definition and criteria. It actually leads to all of those happening, and potentially the testosterone that people were talking about, because they have they didn't realize that it also contributes to the sex hormone binding globulin changes. And this is actually a simplified diagram because a lot of this actually has a two direction. So this is again telling us that potentially we have a reason or underlying factor. Now, I remember what I was going to say. So when we talk about the definition of this syndrome, it doesn't give us a mechanistic or a causative reason for the metabolic syndrome. Okay, but potentially if we can find a causative underlying cause, we will be able to treat it. And I will share a bit more in the second session and treat it early. And one of the things is today's talks, I guess, in the third session, we're talking about obesity. That's before they get problems with diabetes, with heart problems. And then the second session, to me, from the way I look at it, is to treat it after we already have the end organ effects of metabolic syndrome. So I have no more slides really, so I'm right on time actually. I shouldn't have been worried about that. I thought I was talking too much. So remember again, 3 out of 5 criteria. Hopefully everybody leaves this room knowing the criteria and the diagnostic criteria. And then metabolic syndrome prevalence is rising, increases with age. So you have to always look at the age, and male is more than female, at least in Australia. Visceral adiposity probably plays a major role. Doesn't matter which one you use. Maybe it's not the main thing, but it is still a major role. And so you should be thinking about how to reduce that. And I would say consider treating it early, because if we get a diagnosis and we do nothing about it, what's the point? Okay, and so that is pretty much it. I think there is a Q&A later, and you can ask questions at that time too. How much time do we have? Oh. Okay, cool. All right, I have plenty of time for questions. Go ahead.
Thanks, Tien. It's Salim Chalub. I'm a bariatric surgeon. We worked together before.
Yes.
You've addressed every single point from the an endocrinologist's point of view. Visceral adiposity is the major factor in the metabolic syndrome. I normally tell patients that the stomach is an endocrine organ rather than a stomach itself, what we call it. What's your view on that?
In terms of the stomach being an endocrine organ?
Yes.
I wouldn't disagree with that.
So can you just explain to them the reason we call it that? Call it as endocrine organs? Because most of the endocrines, they go to the glands, but I push it a lot because we in bariatric surgery, we target the stomach and the proximal part of the small bowel. I'm talking about it later on and what's the reason behind that.
Yep.
But a lot of endocrinologists, they target medication targeting this organ without calling it as endocrine organ?
They are actually. Unfortunately, as I said, as endocrinologists, we are shrinking in our coverage. We don't do reproductive endocrinology. We no longer do lipidology as much. Otherwise, we would have a lot of things to talk about. Now, Shalim Chalop, I'm not sure if you all know him. He's actually a bariatric surgeon. So obviously, he is very interested, and he will be talking later on, I believe. He's having a debate. I won't be debating with him. I'm scared of him. No, just kidding. And certainly after bariatric surgery, one of the mechanisms, bariatric surgery, they thought that it was a cure, gastric bypass especially, they thought it was a cure for type 2 diabetes. And in some sense it is for some people. Yeah, you can say it's temporary. For some people it's more permanent because they actually manage to keep it off for a long time. Some people, they do regain weight.
I'm sorry, can I correct that? It's a longer-term remission to diabetes, not a temporary. It's a longer-term remission, we call it.
That's why I mentioned.
Thanks.
What your opinion?
Yeah. Yeah. Anyway, and the reason the endocrinologist got very excited, you know why? Because after the bariatric surgery, we find that there is a spike in GLP-1 hormone. Guess what GLP-1 is? GLP-1 is a hormone, right? It's a gut hormone, yeah? So we forget that it's an endocrine organ, so to speak, yeah? What does GLP-1 do? Not fully elucidated, by the way. My second talk actually was originally about GLP-1, but I've changed it to metabolic syndrome. Some of you might recognize some of the talk later on. But the interesting thing there is that this incretin hormone, the GLP-1, is now also accepted as a satiety hormone. Actually, a lot of things are under endocrine. When we talk about obesity, I'm only one of 3 endocrinologists in South Australia that self-profess as working on weight management. I can't get my colleague to be more interested. Think about it, it's an endocrine problem. What is hunger? Ghrelin, what's that? Hunger hormone. What is all those other satiety hormones? They are hormones. And GLP-1 is now inducted as one of the satiety hormones officially. So again, it is an endocrine organ. I agree with that. Yeah. So, it's sorry.
We take the questions in the end.
Yeah, I think we'll. All right. Cool. All right.
Thank you for that, Dr. Lee. Now we would like to invite Associate Professor Prashant Tibrewal to discuss the psychiatric aspects of obesity and metabolic syndrome. Associate Professor Tibrewal is a consultant psychiatrist who is currently the head of unit at the Cramen Clinic and the Mental Health Short Stay Unit at the Queen Elizabeth Hospital. He has an extensive experience in diagnosis and management of mental health disorders and has a very strong clinical and academic focus. He has a keen interest in teaching and is a 2-time recipient of the Professor Derek Fruin AO Citation for Excellence in Clinical Teaching for the University of Adelaide. Dr. Tibrewal chairs the Adelaide Pre-Vocational Psychiatry Program's Curriculum Committee, and his research interests include neurobiology, psychiatric genetics, psychopharmacology, and anxiety disorders reflected in over 57 publications in peer-reviewed journals. Welcome, Dr. Tibrewal.
Thank you for a very kind introduction, and thanks, Dr. Lee, for a very informative presentation. I really enjoyed it a lot, and I think he has set the scene for the whole day. And if you could remember his slides on the visceral adiposity and how complex the pathophysiology of obesity is, then your day will become a bit lighter, because a lot of information lies there as to why metabolic syndrome happens and how obesity sets in. Now, I've put this as my first slide because we really don't know if it's the chicken or the egg, whether psychiatry or psychiatric disorders cause obesity or it is the other way around. I don't know if by the end of my presentation I'll be able to answer that, but we'll try and see if we have some association or some answers that we can do. Like Dr. Lee said, that causative studies are very difficult, given that causative studies can only be either RCTs or before and after studies, and there can be a lot of difficulties in doing them in terms of the topic that we have in hand. So mostly these studies are associations. Now, globally, the prevalence of obesity has been increasing in the last few decades, and it's become a major public health concern. We can thank the urbanization, the industrialization, the eating habits, and so on and so forth. It is not surprising, therefore, that obesity is the 5th leading cause of death worldwide, and it also imposes a heavy financial burden on society. At one level, the pathophysiological explanation of obesity is very simple, like Dr. Lee said, that you take energy and you expend energy, and there is an imbalance between the two. So the answer should be very simple. But given the pathophysiological explanation of how the energy is stored and how it is expended is so complex, it doesn't remain that simple. And that is the main difficulty in managing it when we don't actually know the pathophysiological mechanism behind a problem. Now, I won't go into the metabolic syndrome diagnosis anymore because it has been very beautifully explained by Dr. Lee. This is just one definition, which is the WHO definition. The prime criteria, as he said, is insulin resistance as defined by either an impaired glucose tolerance or diabetes mellitus or impaired fasting glucose, plus 2 or more of the below, which I guess there is not much point in going into because you have spent the first half an hour, 45 minutes of the morning learning that. But just to keep in mind, that's the definition of metabolic syndrome. Why did metabolic syndrome come into picture? Was to assist clinicians in identifying an increased risk of cardiovascular disease. That was the main intent of why it was first defined. It consists of a cluster of abnormalities generally associated with obesity. Now, why am I here talking to endocrinologists, cardiologists, and surgeons about obesity is because for long there has been a bidirectional link that has been considered between psychiatry and obesity. It was first described in 1946 by someone called as Nicholson. He said that emotional tension and psychoneurotic factors were actually associated with obesity. Since that time, there has been a large amount of research examining the links in between these clinical areas, and there has been common links increasing. And it has been found that people with mental illness have a 2 to 3-fold increased risk of obesity. And the risk of mental illness in people with obesity has been documented to range between 30 to 70%, and that's a very large number. Obesity has been associated with a number of psychiatric disorders, and we'll be talking about a few of them. And it has also been understood as a side effect of many of the psychiatric medications that we prescribe. I'll try and touch upon them. It's a very huge area to contain in 20-30 minutes. So some of the slides can be a bit cluttered and loaded, and I apologize for that. I'll try and keep it simple as far as I can. So talking about ADHD, all of us know about ADHD. ADHD is a disorder of children characterized by attention deficit and hyperactivity. This is by far the most commonly diagnosed developmental disorder in children. School-age children with ADHD are likely to have poor physical fitness, delayed milestones, display more negative feelings about physical activities. So setting the scene there right in childhood. Now, almost 60% of these kids who suffer from ADHD go on to become or go on to have residual ADHD symptoms in adulthood, which is called as adult ADHD. Now, if you look at the illness itself, the illness doesn't allow the child or the adult to organize themselves and be impulsive. Now, this can affect not just your eating habit, but also the outcome of many of the interventions that we are trying to do with these patients. Let's say, for example, Dr. Salim Bloch will do a bariatric surgery and would expect the patient to have a regular diet or an organized meal pattern following the surgery. And the patient doesn't have that ability because the brain's not really helping them. So then we falsely attribute the outcome of that surgery to the procedure itself or the nature of the intervention, if it's not surgery. But actually it is something else. The patient possibly wasn't able to manage the pre- and post-operative requirements of the management, which needs to be kept into mind. When they become adults, patients with ADHD will not have the ability to organize sports or organize physical activities in a way that any other person could, which will then contribute to their lifestyle and so on and so forth. Now, could there be a pathophysiology or a link between obesity and ADHD? So, the most, or the easiest thing that comes to mind is dopamine, right? So we know that there is a hypodopaminergia in ADHD. So what happens in ADHD is that the prefrontal cortex does not get enough dopamine. And when the prefrontal cortex is not getting enough dopamine, it doesn't allow the brain to execute the executive control over the lower brain. So there is not an ability of the brain then to control the impulses, to control the emotions, and to be able to be satisfied by normal processes of day-to-day activities, and they seek pleasure in some other ways. Now, food also is a pleasure-seeking thing. So people who are deficient in dopamine in the brain in that sense will use food as a soothing factor, will use food as something that's comforting and which is relieving the stress. So the common link appears to be dopamine, and if it is possible that people with obesity have less dopamine in the brain in some regions, similar to ADHD. That led to the investigation of a candidate gene maybe, and they came up with the DRD4 and tried to investigate whether the 7 repetitive allele of the DRD4 gene was responsible or was the common link between ADHD and obesity, and they have found some success in that. So that was done by an author called as Leviton, and he did examine the possible contribution, which was supported by his investigation. Now, the other disorder that many of you who deal with obese patients will come across is binge eating disorder. Binge eating disorder is when people lose control over the eating and they eat impulsively. The difference between binge eating and bulimia is that there is no compensatory mechanism in binge eating. They don't try to get rid of that food by vomiting or by laxatives and so on and so forth. So binge eating disorder, especially in patients with obesity, it is possible that the impulsivity associated with these abnormal eating behaviors may be a part of the ADHD impulsivity spectrum, and whether they can be a potential barrier to the treatment of obesity thereafter. Moving on to obesity and mood disorder, this is by far the most studied association, that whether obesity is related to depression or depression is related to obesity. So it was found that the prevalence of obesity was almost twofold higher in patients with major depressive disorder and bipolar disorder than as compared to the general population. And many aspects of the neurobiology of depression also confer increased risk of obesity. Now, again, if you remember the slides that Dr. Lee showed about the visceral adiposity pathophysiology, he spoke about the hypothalamic pituitary adrenal axis. He spoke about Cushing syndrome and how cortisol production can lead to increased weight gain. Now, these are all things that are increased in stress. Cortisol is a stress hormone, and whether or not that, again, a depression stimulates the HPA axis, thereby releasing these hormones and leading to increased adiposity. Also, the role of inflammation has been investigated in depression, and there is evidence supporting the fact that both obesity as well as mood disorders, whether it's unipolar depression or whether it's bipolar depression, are associated with chronic inflammation. Elevated levels of inflammatory markers such as TNF-alpha, C-reactive protein, inflammatory cytokines are seen in both obesity as well as major depression. Now, I spoke briefly about whether it's the chicken or the egg. So obesity actually has been a risk factor for incident depression, and depression has been a risk factor for incident obesity. So there is a bidirectional link, and it's very difficult to kind of delineate what came first and which was the chicken and which was the egg. there is evidence to support temporal pathways. There has been research done, and I've just quoted one meta-analysis, which was the largest I found, that the odds ratio of developing depression among those with obesity at baseline was 1.55. And then people who had depression to develop obesity was also 1.58 in non-adjusted and 1.4 in adjusted analysis. So there is evidence for both, that obesity can lead to depression and depression can lead to obesity. A case control study of 293 obese treatment seekers that were gathered from obesity clinics, compared with matched controls, found that the odds ratio was about 3.5 for any axis 1 psychiatric disorder, be it depression, be it anxiety, be it ADHD, and it was 4.3 for axis 2 disorder, which is personality disorders like borderline personality, anxious personality, and so on and so forth. So it's not just a diagnosable major mental illness, it's also the characterological deficits that can also actually influence whether or not you're going to develop obesity in future. Now, post-traumatic stress disorder is known to develop in the aftermath of a very traumatic event by exposure to an actual or threatened death, serious injury, sexual violence, chronic sexual violence, and so on and so forth. So it's like a state of being in a sustained stress throughout the life, not just an acute stress of having met with a car accident or having failed an exam and so on and so forth. It's like someone who is in a duress 24/7, and the brain's actually under threat most of the times. Some minor signals like a sound like this can startle us, but for them it's an actual recollection of the whole trauma that they went through. Mostly seen in war veterans, but not uncommon otherwise as well. In a study of about 500,000 war veterans, the authors found that PTSD and depression were the greatest risk of being overweight or obese and continued to gain weight despite treatment. Just think about it from a behavioral perspective. Like we said, food can be a coping strategy. Food can be a mechanism. So it is possible that in patients who are exposed to trauma, they are using the food as a coping mechanism, as a strategy to soothe themselves, and that is not letting them actually create that negative energy balance, if you like. In addition to that, the dysregulated neuroendocrine functions, including the enhanced negative feedback sensitivity of glucocorticoid receptor, blunted cortisol levels, and catecholamine response, have all been found in adults diagnosed with PTSD. An elevated waist circumference has also been associated with chronic stress in patients with PTSD. We spoke about ghrelin and the appetite instigating hormone that, if I'm not wrong, crosses the blood-brain barrier and releases neuropeptide Y. So that has been found to be upregulated in patients who have chronic stress or suffer from PTSD. So we are losing on all fronts, basically. I did mention binge eating disorder, which is again associated with obesity, characterized by recurrent episodes of binge eating in the absence of regular use of inappropriate compensatory mechanisms. Like I said, they don't vomit, they don't use laxatives, unlike bulimia, unlike some other forms of eating disorder. They eat to soothe themselves maybe, or impulsively. And approximately 30% of patients seeking treatment for obesity will meet criteria for binge eating disorder. It's like an inhibitory pathway, like I was discussing in ADHD, that the prefrontal cortex's control is lost. So if you like, there is an interplay between the prefrontal cortex, the orbitofrontal cortex, and the anterior cingulate, which is the inhibitory pathway. When we are done, what inhibits us from doing something? How does the brain get satisfied that this task is done? It's the inhibitory pathway in the frontal lobe that promotes that, and that is lost in patients with binge eating disorder. And therefore, there is no inhibition to what's going on, and how much they are eating. A kind of temporal evidence comes from the fact that many patients with ADHD who are treated with lisdexamfetamine, which is a stimulant medication, which is supposed to repair that connection and improve the dopamine flow in the frontal lobe is also effective in binge eating disorder and is the first treatment approved by the Food and Drug Administration in America for the treatment of binge eating disorder. Now, it won't be complete without talking about schizophrenia, and largely because of the nature of the illness, the lifestyle, the treatments that we use to treat schizophrenia. I'm sure all of you know about schizophrenia. It's a disorder that's characterized by positive psychotic symptoms in the form of delusions, hallucinations. It's also characterized by negative symptoms like avolition, amotivation, not wanting to do anything. Also cognitive symptoms like inability to decide things, inability to plan things, so the so-called executive functions. So schizophrenia is a dimensional kind of neurodegenerative illness that's characterized not just by positive symptoms, but also by negative symptoms and by cognitive symptoms. And by the nature of the illness itself, it predisposes people to obesity. Now, just talking about the prevalence, schizophrenia patients have high rates of physical comorbidities, including diabetes, cardiovascular diseases, deep vein thrombosis, and pulmonary embolism. The standardized mortality ratio for death from cardiovascular diseases is doubled in schizophrenia as compared to that of general population. And they have a shortened lifespan of independent of suicide risk. Now, over life, the reported prevalence of overweight and obesity in patients with psychotic spectrum disorder ranges from 40 to 62%, which is a very large number. And unfortunately, these are the patients who don't get treatment, either because of their own evolution to seek treatment or because of the healthcare providers' stigma towards them in a way that they don't get the medical treatment that they deserve. Now, factors commonly implicated in the development of obesity in people with schizophrenia include sedentary lifestyle, lack of exercise, and poor dietary choices. The mechanisms, like we said, are complex. One of the mechanisms could be introduction of second-generation antipsychotics. When I was doing my master's in psychiatry, we used to have a lot of first-generation antipsychotics, so-called haloperidol, flufenazine, zoclopenthixol, so on and so forth. These first-generation antipsychotics were not metabolically very active, but they had a whole array of other side effects. Does anyone know what they do? Are there any neurologists in the room? So they used to cause extrapyramidal side effects or Parkinsonian type symptoms. So tardive dyskinesia, tardive dystonia, and most of these neurological side effects would be irreversible. And not only that, it predisposes them to more stigma, because imagine a person who is behaviorally odd is walking on the street with a mask-like faces with saliva drooling from the angle of his mouth. They are likely to be seen as an outcast and likely to be ostracized because they don't even look like us, right? So it was something that went out of fashion because of those side effects, and that they were replaced by second-generation antipsychotics. Now, these second-generation antipsychotics did not have the neurological side effects, but they brought with them a plethora of metabolic side effects because of their actions on the serotonergic receptors in the brain, the histaminergic receptors in the brain, and so on and so forth. And that has given rise to a problem that we are finding very difficult to contain. We will talk about the role of the medications in a few slides because I thought it was worthy of being discussed for more than one slide. So I'll just go through first the other aspects, and then we will go to the medication side of it. We know that in patients, it's like we spoke about medication, but even if you look at schizophrenia patients who are drug naive, they also have an increased rate of obesity. And why could that be? If the medicines that I'm giving are the only reason for obesity, then that wouldn't have been the case. So it's more than that. They at baseline have increased abnormal glucose metabolism, diabetes, and impaired glucose tolerance in drug-naive patients were found, indicating that iatrogenic weight gain was not the only reason. Increased leptin has been reported in antipsychotic-naive people with schizophrenia. Now, leptin is an anorexigenic hormone that again crosses the blood-brain barrier and asks us to stop eating. And the disturbance in the leptin levels, along with the ghrelin, then dysregulates the whole hunger appetite and satiety balance in the body. Other factors that can contribute to increased weight gain are amotivation, high rates of substance abuse, and aberrations in cortisol production, and even comorbid depression. So moving on to substance abuse, both drugs and certain types of food, like food rich in simple carbohydrates, food which are energy dense, are considered to induce tolerance over time, whereby increasing amounts are needed to reach the same satiety, both for alcohol, say for example, for cannabis, for amphetamine, and for fast food, what I'm trying to argue. In addition, withdrawal from them will lead to dysphoria, will lead to symptoms of not being so happy. So if I don't get the alcohol, I will not be that happy. If you ask me not to take amphetamine for a day, I'll be in a withdrawal syndrome, and so on and so forth. And similarly, food can also do that. In vulnerable people, through genetic liability or through individual factors, reinforcers in the form of food or drugs become overvalued related to other reinforcers. And there is an elevated expected or anticipated reward overactivates the memory and reward circuits and inhibitive cognitive control. I'll give an example of that. I had a patient who had nicotine dependence syndrome. I was a young consultant in a de-addiction center trying to treat him, giving him nicotine replacement. So logically, if someone smokes cigarettes, they get, say, a definite grams of nicotine in a day, and I'm replacing it with chemical nicotine. It should suffice the withdrawal, right? It doesn't. Why is that? Because it may not just be a physiological dependence. It may not just be a physiological withdrawal. There are many things that you want to say something. No, sorry. Yes, of course. And so what he described to me taught me a few things about memory, reward circuitry, and cognitive control. So he said, doctor, it's not just the cigarettes. I have a Zippo lighter. As soon as I click that lighter, the sound of the lighter starts evoking dopamine in me. I press on the thing, the flame itself induces euphoria in me. And then I have the cigarette in my hand and the smoke. All of this combined is the cause of the euphoria. Your nicotine patch is not doing it to me. I need it all. Right? So the reward circuitry starts to fire even at the site of something that is associated with that paraphernalia. And similar responses have been seen in people at the site of a fast food, at the site of a sign of McDonald's, at the site of a sign of Hungry Jack's. So it's a cue-based reward circuitry firing in the midbrain with the ventral tegmental area to the pituitary where the reward center is located. So it's a very, very intricate mechanism which is not just it's not just you replacing the simple carbohydrate, it's more than that. So that is a common link between obesity and substance abuse and how the reward circuitry can actually play a role in that. And they have lost the capacity to self-manage because of the loss of control, which is a part of the reward pathway again. Then there are endogenous opiates. Dr. Lee mentioned naltrexone and some other drugs, alcohol craving drugs, which are being used in obesity. Now, we all have endogenous opiates that act on the mu receptors. So there are 5 types of opiate receptors, of which the mu receptors are responsible for most of the craving phenomena. Now, naltrexone is an opiate antagonist that is used in treatment of craving from alcohol and so on and so forth. It has also been combined with buprenorphine and is being used for weight loss. So buprenorphine-naltrexone combination acts on the same receptor in a weight loss program as it does in an alcohol dependence program. Compounds that are inverse agonists with the endocannabinoid system. There is one compound that came into the market, which was rimonabant, which was withdrawn from the market because it caused suicidal risk and increased dysphoria upon withdrawal. So that is something that we also need to know. Now, talking about whether intentional weight loss can lead to some sort of psychiatric disorder. There was a classic study done by Keyes who found that normal weight males who intentionally lost 25% of their body weight experienced a variety of severe psychiatric syndrome, including hallucinations. In addition, Stunkard reported a constellation of distressing emotional symptoms in obese women who participated in weight loss therapy, and he called it as dieting depression. So if you're dieting, you might feel dysphoric. And then these reports have been coupled with more recent findings of the rimonabant that I said that rimonabant caused weight loss, and then that led to suicidal ideation. However, there is, on the flip side, there have been many positive studies from weight loss programs that people found their body image to be more acceptable and they were happier after the weight loss and so on. So it's not just that weight loss will lead to a negative psychiatric syndrome. It can also improve your self-esteem, your self-image, and thereby improve the depression. Effect of psychiatric disorders and outcomes, like I briefly again touched upon that if someone's actually suffering from a psychiatric disorder, will the weight loss program be affected? It would. But strangely, the studies have not been one way or the other. There have been studies that say, okay, there is actually a negative outcome. If you have a pre-morbid psychiatric diagnosis, weight loss program will not be that effective. There are some studies that say that's not true. There can be no association. But the consensus is that it is good to rule it out. It's good to get it treated if you actually have a psychiatric disorder before you enter into a weight loss intervention program. Now, I've been told I've got less than 5 minutes. I'll try and quickly wind up the obesity and psychotropic medication part that I was going to explain. So psychotropic drugs include antipsychotic medication, antidepressant medication, mood stabilizing medication, anti-anxiety medication, and most of them are associated with weight gain. Amongst antidepressants, the most common culprits are mirtazapine and tricyclics. Amongst the mood stabilizers, the most common culprits are lithium and sodium valproate. Amongst the antipsychotic medication, the most common culprits are the second generation antipsychotics like we discussed. And that's something that I would dwell on for a few minutes if I'm allowed. So these are some of the serotonin dopamine agonists or the second generation antipsychotics like I was trying to explain. Clozapine is the most effective antipsychotic, that is a third line agent in the treatment of schizophrenia after 2 antipsychotics fail. Now, clozapine is also associated with a lot of weight gain, diabetes, morbidity, mortality. There is a differential metabolic lability. If you look at the bottom of the slide, so clozapine is the worst offender, followed by olanzapine, and then comes risperidone and quetiapine. The last two, aripiprazole and ziprasidone, are more or less weight neutral. The caveat being that they are not as effective as well. So when you're struggling, you might want to go to a drug higher in the hierarchy, thereby exposing people to metabolic syndrome. The precise mechanism by which they cause obesity is not really understood. But if you look at their receptor sites, all these SGAs act on norepinephrine, serotonin, histamine, dopamine, which are all the receptors involved in weight regulation. Neurohormonal changes were demonstrated in patients treated with SGAs, and there was evidence to suggest that peripheral metabolic hormones, again, leptin and ghrelin, could play a role in alteration of regulation of food and energy balance, and that could be a result of the SGA medications. There is an increased risk of diabetes with clozapine and olanzapine, and there is an increased insulin resistance secondary to weight gain. Whether it's secondary to weight gain or whether not, that Dr. Lee will let you know in subsequent presentation that he has. And then we have incidence of increase in LDL and decrease in HDL in patients treated with clozapine and olanzapine. This is just a photograph or a diagram I took from a book called Steven Stahl, and this represents what is called as a metabolic highway. And it says that when we are treating someone with second generation antipsychotics, there are 3 spots in which we can intervene, and it's best to intervene early, which is at the stage of increased appetite and weight gain. The next step would be increased triglycerides, and thereafter the next step would be beta cell failure, which will lead to diabetic ketoacidosis. So three spots for intervening: weight gain, fasting triglyceride level, and the last would be beta cell failure, which would then be education about symptoms of diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome. Now, how do we manage the weight gain induced by antipsychotics? Lifestyle modification, dietary advice. So people with schizophrenia would go into a supermarket and would come back with one big box, 24 bottles of Coke, full sugar. There's no intent to read the label. So education about reading the label, education about if you want to eat it, how can we reduce the risk there? Some lifestyle modification, getting something active during the day, scheduling the day in a way which they can't do with themselves, rationalizing the antipsychotic regime, maybe moving on from olanzapine to the aripiprazole. And then a recent Cochrane review has once again affirmed metformin has been there for a long time in the management of antipsychotic-induced weight gain, but time and time again, this has been reaffirmed that metformin is one of the best medications if you're worried, if your patient is at risk, start it with the treatment. As soon as you're prescribing someone olanzapine, start metformin. And that's the first line evidence. That brings me to the end of my presentation, and just wanted to say that there is a relationship between obesity and psychiatric disorders. It has been associated with a number of disorders like we see, and there is definitely a bidirectional link which we need to yet understand completely. Thank you so much for listening.
Thank you so much for your insightful presentations, Dr. Tien Lee and Associate Professor Prashant Tibrewal. We now invite you all to ask questions during a short Q&A. We'll have a roving mic, and please just raise your hand to ask questions from either of our speakers.
My first question is with Dr. Lee. You mentioned obesity is obviously not a good word to say in front of the patient. So what word do you use? Because I had a patient and he was like, oh, I'm not big, I'm just cuddly. So I don't know. I mean, is there any particular word that you normally use?
I don't think that's a very good question.
Yeah.
I don't actually talk about obesity as such. Maybe it's because we have already mentioned that, and Prashant has said as well, with anyone with psychiatric conditions, anyone with weight-related conditions, and there's so many of them, pretty much the whole textbook, okay? So I actually address the problem. For example, if they come to me with diabetes, is the easy one, okay? Then I say, look, you know, I do it slightly differently. In fact, that's going to be my second talk slightly. But really, I will be addressing diabetes. And I say there's two different ways to approach it. One is the traditional way, where I just give you a medication, and then I'll give you a second medication, and I'll give you a third, and then in the end, you're going to be on insulin. So it's a chronic progressive disease, right? So, but the other possibility is, if you want, we can make some lifestyle modification. We can actually work with you, and we might be able to actually simplify your 3 medications you're coming with right now to see me, and maybe we will end up with just metformin. And so there is some kind of reversal going on because you're only on 1 medication and your HbA1c goes from 8 point something, 9%, 10% to 6%. Okay, so that means something must have changed, right? So that's an offer that I give to all my diabetes patients of type 2. Yeah? And about 80% of them actually accept that challenge. Of that 80%, actually most of them actually do carry through because they see the results. So I actually think that we don't have to specifically use the word or talk about it because, and there is also in the literature, they actually have a proposal of how to approach this, by the way. And the first step that they actually put was ask for permission. If you all have any of those talks, like for like Saxenda, you might have a speaker who came out and their slide says, ask for permission, step 1. I was asked about that and I said, no, I won't present that slide. I don't do it that way. Because they came to me for healthcare. Yeah. It's my duty of care. I'm trying to help them with their conditions. I'm not even talking about obesity, I'm talking about all the other. If they came in with osteoarthritis, if they came in with needing a knee replacement but they need to lose some weight before, if they came in with gout, we have already mentioned that, uric, thyroid problems, etc. All of those are somewhat related. So I would actually address it and talk to them about what I know and how it's related to potential lifestyle changes that they can make. So you don't actually need to actually talk about obesity as a separate thing.
Yeah. Sorry, one more thing, Doctor.
I just wanted to add to that. It's a very good explanation Dr. Lee gave, and I come across that problem more often than others, because telling someone that you've got psychosis or bipolar is not easy, and they can be offended by it, is what my initial thought was. The way we put it to the patient can actually be empowering for them, and they can actually take it better than say for example, I said to one patient in my younger years that you're overweight, and she said to me, "Thank you for telling me that." So she was obviously hinting to me that I know this, and tell me something new. How does that help? And that's not what they want to hear, though. What they want to hear is possibly what could be the solution to it, and that's what Dr. Lee is possibly referring to. So say if someone's coming to you with an obesity, but they have not come to you for obesity, I guess they have come to you for something else, and you give them the good news that, hey, look, I think this is actually associated with weight, and you might actually benefit from these interventions, and that might actually be a bit more acceptable way of explaining it to the patient.
So first of all, I have a comment for Ima for congratulations for arranging this wonderful day for all of us. It's getting bigger and better. So the first one was at Hilton, and this one is looking even better and bigger, and attendance is tremendous. And I look at the agenda, which seems full of wonderful talks, and I must congratulate the president and all the organizers for that. And I've got a common question, one each for both of you. For you, number one, so he recommended routine use of maybe metformin when you initiate a serious antipsychotic for the patients to prevent obesity, or maybe start treating the metabolic syndrome straight away. So for pre-diabetes, do you recommend use of metformin straight away as we just diagnose it? Or?
Definitely. Actually, in the diabetes prevention trials, it's quite clear. Number one, lifestyle. Number two, metformin. Now, metformin is unfortunately, it's probably number one oral medication throughout the world, except maybe China. I heard that acarbose was number one. I think that has changed now. And it's one of the safest drugs on the market, you know that? Yeah. 70 plus years on the market. 50 years scrutinized because of fenformin. And each year that goes by, the safer we think it is. In fact, if you go by evidence, we don't even need to stop it for surgery. We do. So I was one of the scribes for the Australian Diabetes Society for their perioperative guidelines. And when we were discussing, we say, hey, actually evidence says that it doesn't need to be stopped. But we decided to keep it stopped as our recommendation in that guidelines, just to keep it uniform. No confusion, okay? Because there's no harm, one day off. AMH has actually said that you can use it all the way down to EGFR of 15 for a long time. I haven't checked what the TGA guidelines is, by the way. So I don't know whether it's considered off-label or not. But you know, we used to be so worried about it. But there is actually, it's one of the safest drugs. So I agree, you know, if you are concerned, and I'm going to share about some reversal of diabetes stuff in the next talk. I see if I can remember to mention it. But I actually keep people on metformin if they don't have what I call a complete remission, which is no detectable diabetes is the other way I call it. And I will share that in the next talk. So I think it is one of the best things if they don't have any side effects. Of course, if they have diarrhea and all that, you cannot expect them to do that. Now, in terms of weight, I think it's not just about the weight though. It's actually about the insulin resistance in this case. Rule of thumb, it reverses insulin resistance by about 30%. Not perfect, okay? But it's one of the good drugs that can do that, and safe, as I said. It probably, most probably is generally weight neutral, unless the person has some problems and have some diarrhea and not absorbing. So, but I wouldn't count it for weight loss. Those people who lose weight on it does lose quite a bit of weight. So,
thanks. And from Prashant, you mentioned your great presentation that a bit of prevention of the obesity in people with binge eating disorder by use of dexamphetamines. It's been approved by FDA. So how about Australia? Have you used it at all, or it's you think in process that we will get that approved and it will be used in future in market here?
Well, as of now, it's an off-label use, so it's not approved, to answer your question. Whether or not it will be approved is difficult to answer. As such, Listex is being abused in a way by ADHD patients. There is a lot of scrutiny. It's a Scheduled 9 drug. What that means is that every time a GP or any other professional need to prescribe Listex, they will have to send the patient to me for authority. So it's quite restricted. We are being made the gatekeepers. So I'm not sure whether it will be approved for binge eating or not, but I think there is always an opportunity to make a recommendation and develop it. So does that answer your question? Yes, thanks.
Just a note there of interest. Have you ever tried things like phentermine? Because it's also a related drug.
Yeah, so it has been used for weight loss. But if you collate the evidence, the evidence of phentermine for weight loss in binge eating disorder is less as compared to lisdexamfetamine, but it can be used. Yeah.
The reason why I ask that is, of course, for patients that nowadays, actually, if somebody has come to me for weight management and says that, oh, I've actually previously lost a lot of weight on phentermine, but I can't stand the side effects after some time. Some of them start to actually develop later on, the side effects. I actually start suspecting ADHD or one of these binge eating disorder. And very often I do the screening test for ADHD and they will be positive. So it's actually undiagnosed ADHD going on and they actually respond very well because they are all symptomatic. So it's quite interesting.
It's quite likely, thanks.
We are ahead of time. Just one last question and then we move on to tea break after that.
Thank you. This one's for Dr. Lee. I know you said that we're not supposed to treat each individual problem in metabolic syndrome, but as a GP, not just to focus on that problem, but as a GP, we often see fatty liver disease, and it's really frustrating because they may have different degrees of steatosis on ultrasound, but have a normal cholesterol. What would you recommend? Is there a link between metabolic syndrome and the degree of steatosis, for example? And what would you recommend as a sort of, first line?
Well, that's going into the territory of gastroenterologist. But you do know that all the drugs that we use for weight loss and all that, they are starting to actually come out with the data and research to show that it actually works for fatty liver. So you're going to have GLP-1 for the gastroenterologist soon. In fact, that's their next frontier, so to speak. I'm going to say that, look, fatty liver is not your real problem. The other bigger problem is when do you send them for fibroscan? In one of the studies in the US, up to 18.2% of people seeing an endocrinologist with no known liver problems, and then they screen with a fibroscan, 18.2% actually came out with some severe fibrosis or cirrhosis already. Okay, so that's huge. And so the guidelines is still being played out. Who do we send? Okay, and you can send it to RA as well. I sent one just because of obesity. Everything else was fine. AST, ALT was still in the normal range. They actually did it because the FIPS-4 score was a bit higher. So that's one of the predictive scoring. So what I'm going to say is this, medication-wise, not many. If you really want to try, don't quote me. I'm not medico-legally responsible. Pioglitazone is a very unused drug. It's for diabetes, so it's under the endocrine territory. Gastroenterologists might not know about it or might not use it. It's actually a pretty good drug for them. Now, but I don't think drug is the answer, isn't it? I think, by the way, the current management, just in case, your first statement, the current management is to treat the individual components of metabolic syndrome, okay? But I'm saying that by the time you get those individual sequelae, which we are talking about in session 2, right? We will already be doing all the other stuff anyway. Well, cardiology problem, we'll do the cardiology, we'll do the diabetes. So there's no change in the management. The real change in management is to get it early, and perhaps you can get those people on that table to help with the obesity part of things, which is in session 3. So I think that it's actually talking to them about lifestyle, reduce carb intake, for example, simple measures, some intermittent fasting, for example, eat within an 8-hour period is some of the simple things that I would do. And that is where I would go instead of medication. Now, how do you approach that? I think you can say that fatty liver is an increasing problem. It doesn't, like you have mentioned, it's not that closely related to the lipid levels in the blood, okay? What I say is visceral fat, it's not the cholesterol that's floating in between. And that cholesterol floating inside, that is still under a lot of research, because if you look at those people who do a keto diet, I just had one this week, total cholesterol is over 10. Okay, so where do we go with the guidelines there? I mean, I don't do keto personally. I do have some patients is on keto, but very, very few for specific reasons. I just do low carb. Okay, but their risk, coronary calcium score is 0 for that patient, and they might not have any increased risk despite the high LDL and total cholesterol. So, I won't go into that. That's a whole different ballgame. But I would say, look, you know, the blood test results, those lipid levels may not have anything to do with the fatty liver itself.
Thank you so much, Dr. Lee.
Can I ask one quick question, Abdul, if you don't mind?
Yes,
Sorry.
sure.
To Dr. Lee, you mentioned the European classification of metabolic syndrome excludes diabetes. I was just curious to know, what is the implication for research? How do you interpret data if one of the major classificatory systems excludes diabetes?
Yeah, luckily that is quite old, and most people, according to the 2023 survey, as I mentioned, almost all the Americans are using their American system. And the difference between the American system and the consensus system since 2009 is just that we have ethnicity involved in the consensus guidelines, which the American is just using the one standard waist circumference for the Americans. So as a result, hopefully we won't get into too much of that problem, but you are absolutely right. If you get any older studies that still uses the European, you have to interpret it differently from all the rest.
Thank you so much for providing your expertise and for that wonderful Q&A. We would now like